دكتور أديب.
Yeah, I think there's a net issue.
Yeah, there is a net issue, so I will call him 1 minute. I think he will be reconnecting. Hello, Dr. Adib. No problem at all. Just reshare. Yes, no problem.
I'm sorry. I apologize for this technical issues that I'm facing. So I don't know where I was stopping, but I was talking about the venture trial, where it's basically they included all comers, all asthmatic patients who were on oral systemic steroid on daily basis. So this is exactly the study or the inclusion criteria for both studies. As you can see, they included all comers regardless of their eosinophil counts. Everyone got into study. The people with the Quest trial, they had medium to high dose ICS plus another controller, but maybe you have a third controller as well. But the Venture trial, it was only people with oral systemic steroid, regardless of using other controller or anything. But they have to be on. They have to be on oral ICS, but also to have to be on oral systemic steroid, regardless of eosinophil counts. They have to have asthma where their FEV1 it's less than 80%, and it should to be severe asthma in Quest trial, but not necessarily the ACQ on the Venture trial. And the FEV1 to documented asthma, it was mandatory in Quest trial, but this should be documented a year before the study started. So in the Quest trial, they have to have exacerbation, at least one exacerbation per year. And then the Venture trial, they don't have to have any other exacerbation, but you have to be on oral systemic steroid. So the main primary endpoint for the Quest trial, it was to change an FEV1 after 3 months, and also the annualized rate of exacerbation rate during the treatment period. And in the Venture trial, the main goal is to see how much reduction of oral systemic steroid after they start the dupilumab. And the study design was to study all the comers over all population, and then the subgroup analysis for people at above 300 eosinophil count or above 150 or less than 150. And the same thing with the Venture. The only thing more in Venture, they included the FeNO in their analysis as well. So just to give you an idea, and I want you to look to these two columns. As you can see, all of them, both studies, they had similar data. They have similar people where the mean eosinophil count is 300 and above. And this was equivalent or equal in both arms, the placebo and the Dubi arm. And both of them as well, they had allergic or atopic, should I say atopic asthma, where their IgE is high, more than 100 or 160. So it was high in both groups. So you can call it mixed phenotype were included in the study, in both study. And the FeNO was more than 25 particle per million. And as you can see here, there were quite severe asthma with uncontrolled asthma with at least 2 exacerbations per year, and we're talking about the mean in both study. So both study they had equal or similar patient population. And this is very crucial. As we said in the comorbidities and other diseases, when you get those patients with type 2 inflammation, don't think about asthma alone. You have to dig in, you have to look up other comorbid disease, and believe me, you will find one. So about 80% of people on Dubi or people who got Dubi, the column is not showing to me, but about 80% on people on quiz trial, they had other atopic condition, either allergic rhinitis, chronic rhinosinusitis with nasal pulposis, food allergies, but they had, or atopic dermatitis, but they had another atopic disease. So we are talking about 80% of people, they have another atopic disease. And the same thing was found on the VISIA trial. They similar percentage, about 70 to 80%. So what was the finding? And this is very consistent with most of biologics. We had overall the intention to treat analysis, we had about 50% improvement or reduction in exacerbation rate compared to placebo. But the things that I was mentioning with all biologics, that we see the higher eosinophil counts, the much reduction of exacerbation. So if you have a patient who has 300 eosinophil counts and another patient who has 900, I would anticipate people with 900 eosinophil, it's like going to have higher response, higher reduction in eosinophil in exacerbation. However, that does not exclude even people as low as 150. They have about 60% improvement or reduction in their exacerbation rate. And that's quite fascinating and interesting. When we know that the eosinophil counts, normal eosinophil counts is between 150 and 300. So if I go myself and test myself for eosinophil counts, probably my eosinophil counts probably is 300. So we are talking about even close to normal or normal eosinophil counts. Those patients with severe asthma, they still have a good chance and benefit from those biologics. And specifically, we're talking here about dupilumab. And that was very consistent with the data with the FeNO on exacerbation reduction or reduction of exacerbation rate, where all comers, about 50%, they had reduction in their exacerbations. But the higher FeNO that we go, the higher reduction in exacerbation rate. Interestingly, compared to the ABV, compared to eosinophil counts, where in people with less than 150, we don't see that much improvement in ABV1. But when we did this with FeNO, even in FeNO of less than 25 particles per million, they still had very good chance to have reduction in their exacerbation. That's why I concur, and second, the importance of FeNO to have it in our clinic and to help and guide us in managing those patients. Especially that we know that FeNO, it's mainly targeted by IL-13, and IL-13 is not that much affecting the eosinophil count, but it do affect the FeNO. And we know that dupilumab, it's really affecting and targeting the IL-4 receptors, which prevent the signaling of IL-13. So that was not the thing, only reducing exacerbation rate. We also saw that with the dupilumab, there is a significant improvement in ABV1, as high as difference of 130 milliliter difference between placebo. But again, as I said, the higher eosinophil counts, as you can see here, the higher eosinophil counts, the higher improvement in ABV1. So when you have a very high eosinophil count, you should expect that patients should respond very well and interestingly to those biologics, and specifically to dupilumab. So in summary, we have a prevalence of 4 to 9% in Saudi Arabia, yet I want to confirm that with a good, well-structured study. With that, our patients probably about 20%, if we take that to international figures, about 20% of our patients, they might have severe asthma, and a subset of those patients, maybe they have uncontrolled severe asthma that require further assessment and referral to asthma clinic or specialized clinic. We have to take into consideration patients who has inadequately controlled with severe asthma, they don't only have higher exacerbation rate, but also they are affecting their quality of life, but also it's affecting the healthcare system, affecting the society, and affecting, and they maybe get so much side effects from the medication. Asthma, severe asthma causes substantial burden of disability. The estimated annual asthma-related costs for patients with uncontrolled asthma are greater than patients with controlled asthma. As you saw with Dr. Riyad, it's sometimes cost as high as patients with diabetes, and we see other patients with advanced renal stage disease. They cost a lot. The same thing I could extrapolate in asthma. Those patients uncontrolled asthma, they maybe cost a lot if we don't control them early on and prevent further progression. I think IL-4, its receptor antagonist, is an excellent option for type 2 inflammation with severe eosinophilic asthma, as well as asthma with other comorbidities that we have to look and search for to completely manage the patient as a one unit. And with that, thank you so much. And now for your question.
Thank you so much, Dr. Adi, for this extensive review of the topic. And now we're going to have we have time for about 20-25 minutes for question and answer. We would like, so please, if you have any question, you can just write it in the Q&A session, so we can, so I can read it to both speakers. And most question would like to have the opinion of both experts, so we can have the best out of it. There's here a question from Dr. Ihsan Sabri, talking about we have long knew that